In the non-alcoholic fatty liver disease, is it rare in children? Non-alcoholic fatty is not rare in children. We can't afford because the new millennium and the new consequence of the obesity epidemic, and is the hepatic manifestation of the syndrome. Non-alcoholic fatty liver disease is defined by hepatic steatosis evidenced by imaging and histology, and the absence of secondary causes of fat accumulation. So we first exclude the secondary causes of fat accumulation, that is excessive alcohol consumption, which is not usually present in pediatric population, and the starvation or malnutrition, and the medication, mostly the valproic acid and the corticosteroid and the methotrexate, and the parenteral nutrition and the hepatitis C, genotype 3, and the other hepatic metabolic disease like Wilson's disease. Before discussing about the non-alcoholic fatty liver disease, we must know the brief history of the non-alcoholic fatty liver disease. The fatty liver is first described by Thomas Addison in 1845. But later on, different authors published their articles in the renowned journals. But in 1980, the Ludwig et al. First coined the term non-alcoholic steatohepatitis. The liver biopsy specimen exhibited alcoholic hepatitis, but alcohol intake is denied in these patients. And later on, 2011, the metabolic associated liver disease is used, the term is used, and in latest 2020, Islam, Chanel and George, on the behalf of International Consensus Panel of 22 countries, said that the term the metabolic associated fatty liver disease, which is a term hepatic steatosis associated with out of the three criteria: overweight or obesity, T2 diabetes, and metabolic derangements. There are some common association of the NFLT. The most important is central obesity, when the waist circumference is more in case of children, and but lean NFLT can occur. Diabetes mellitus type 2, dyslipidemia, polycystic ovary syndrome, hypothyroidism, and obstructive sleep apnea. There is a spectrum of NFLT from healthy liver. When the multiple insults occur, it leads to simple steatosis, a simple accumulation of fat in the liver. It is called non-alcoholic fatty liver disease, where there is no inflammation, and when it goes to the further insults occur, it leads to non-alcoholic steatohepatitis, that is accumulation of fat associated with inflammation and hepatic cell damage. And in this case, in this part, it may progress irreversibly or reversibly goes back to normal liver. When the insult persists, it goes to the liver cirrhosis, where the liver there is activation of the inflammatory cascade leads to fibrogenesis. So the liver cirrhosis occur, and some of them goes to hepatocellular carcinoma. NFLT is broadly categorized into two parts: the non-alcoholic fatty liver, which is mostly benign, and there is abnormal collection of fat in the more than 5% of the hepatocyte without inflammation, mostly triglyceride. And the most severe form is non-alcoholic steatohepatitis. There is excessive accumulation of fat in the liver with hepatic inflammation. What is the prevalence of NFLT? The overall global prevalence of NFLT is around 25 to 2%, and using ultrasonography or estimation of serum ALT, the prevalence of NFLT in children in general population is about 7% and up to 34% in the obese children. And the study conducted by the Journal Pediatrics of BSMU showed that there is around 40% of the obese child suffering from NFLT. The pathogenesis of NFLT is the main primary and the main factor of dysregulation of fat metabolism is the main factor. Insulin resistance is the main factor, which promotes gluconeogenesis, glycogenolysis, and free fatty acid release from the adipose tissue. So the fatty liver means the increased lipolysis from the adipose tissue, decreased fatty acid oxidation, and increased de novo lipogenesis. The NASH histology shows the progression of the simple steatosis to the balloon degeneration, and the cell size is increased. There is a pale cytoplasm and the formation of myeloid dim body in the cytoplasm, and eventually leads to fibrosis. The pathogenesis is insulin-resistant adipose tissue leads to compensated steatosis. Then increased hepatic insulin causes increased plasma glucose, which leads to steatohepatitis. Then it causes lactose activation, which leads to transforming growth factor beta activation. So the hepatic stellate cell is activated and fibrogenesis occurs. In 1998, the Day and James first coined the term two heat hypothesis. The first heat is insulin resistance, and the second heat is oxidative stress that leads to inflammatory cascade activation and leads to fibrogenesis. That is, the diagram shows that increased fatty acid release from the adipose tissue due to insulin resistance. This free fatty acid goes to the liver and formation of triglyceride, and this causes the oxidative stress that leads to inflammatory cascade activation that leads to fibrogenesis. But the hypothesis is too simple to explain the complex nature of the pathophysiology of the NFLT. So the multiple hypothesis comes to the side. Multiple parallel His hypothesis. Multiple insults acting together synergistically on a genetically susceptible subject. The diagram shows the first heat. That means there is insulin resistance cause lipolysis from the adipose tissue, and this causes increased serum free fatty acid. That leads to increased free fatty acid cause triglyceride deposition in the liver that causes lipotoxicity, and this causes mitochondrial dysfunction, and increased reactive oxygen species leads to inflammation, apoptosis, and fibrosis. But this hypothesis is not that simple to explain the complexity of the NFLT. Here, the adipokines plays the role, and the dietary factors, and also the genetic factors, and gut microbiota, and the increased gut permeability leads to development of the NASH. So the multiple insults, I want to discuss some points of multiple insult. The insulin resistance is the still the main factor for developing NFLD, and the insulin resistance is caused by the increased adipose free fatty acid released from the adipose tissue, increased de novo lipogenesis in the hepatocyte, and altered production of the inflammatory cytokines and the adipokines. And adipose tissue inflammation, in case of obesity, there is low-grade inflammation by producing the pro-inflammatory cytokines, interleukin-6 and tumor necrosis factor alpha. These are increased in case of obesity and insulin resistance. And the adipose tissue releases adipokines, that is leptin and adiponectin. Leptin increases in the obesity and activate the hepatic stilacid, which leads to fibrogenesis. And adiponectin is reduced in case of obesity and the NFLD. The intestinal microbiota and gut-liver axis comes to the scenario of NFLD when the other genetic other factors are is interlinked with gut-liver axis. That is, bacterial endotoxin liberated by the gut microbiota goes to the portal circulation, and it causes the fibrogenesis and the NASH. And the increased gut permeability, and there is alteration of gut permeability, and also there is increased production and absorption of gut short-chain fatty acid, and increased delivery of the microbiota ethanol to liver, and there is also like bile acid pool, altered bile acid pool by microbiota. There is also the activation of the toll-like receptor, which is increased in case of obesity. And the high fat and a high carbohydrate diet also causes the two types of bacteria, that is Verruco microbia and the proteobacteria, are associated with high expression of the toll-like receptor, which causes liver injury. And the dietary factors are also very important. And the excessive fructose consumption promotes de novo lipogenesis, and there is increased expression of toll-like receptor in case of excessive fructose consumption. And if dietary choline deficiency occurs, then it causes NFLD. And saturated fat stimulates de novo lipogenesis by upregulating SREBP. And genetic factors is very important. PNPLA3 is the lipogenic gene which encodes the enzyme that breaks down the TG. But PNPLA plays the role when there is no obesity or no insulin resistance, but only PNPLA3 is present. It causes NFLD. And TM6SF2 gene is also important. And the oxidative stress, we know the oxidative stress plays an important role. So it causes oxidative modification of the cellular large molecules like DNA, lipids, and proteins, and it causes damage to the macromolecules, leading to liver injury. And this oxidative stress causes by the mitochondrial dysfunction. That is, mitochondrial beta fatty acid oxidation is reduced. So there is increased lipid influx, altered respiratory oxidation, and there is overproduction of reactive oxygen species that leads to the inflammatory cascade activation and that leads to fibrogenesis. And the endoplasmic reticular stress is another new factor in the field of NFLD, which normally endoplasmic reticulum is used in protein folding, repairing, and trafficking. So when there is endoplasmic reticular stress, there is a decreasing of this protein folding, repairing, and this unfolded protein or misfolded protein is called the unfolded protein response. There is an increased unfolded protein response leads to cellular death signaling, and there is activation of the GNK also induce apoptotic pathway. These are the overall pathophysiology. Better understanding of the pathophysiology is important because this can develop the novel therapeutics in the field of pediatric NFLT. So thank you from my part. Thanks for
Thank you, Dr. Lamia Nahid, for your very nice and informative presentation. Now I would like to request our second speaker to deliver her presentation, Dr. Fahmida Begum, Associate Professor, Department of Pediatric Gastroenterology and Nutrition, BSMMU. Dr. Fahmida Begum, over to you.
Assalamu alaikum and good afternoon. Respected chairpersons and a line of experts and distinguished participants. I must welcome all again the most time-demanding topics, NAFLD. Is it rare in children? No, it's not rare. Our previous speaker discussed that. It's the most important cause of chronic liver disease.
আপনার রুমে আরেকটা ডিভাইস চলছে, ওইটা একটু মিউট করেন। ফাহমিদা ম্যাডাম, আপনারা এই কারণে একটু হচ্ছে, বাকি সব ডিভাইস
My talk will include initial presentation of NFLD and screening and diagnostic tools and management portion. So let's get started. So how they present? NFLD patient presents at the mean age of 11 to 13 years, and they are mostly asymptomatic. Sometimes they present with dull or aching pain in the right hypochondria, and sometimes they present extreme tiredness, weakness, and liver might be slightly enlarged. And there may be acanthosis nigricans, that is dark black spot over dark hyperpigmented area over the neck and the underarm area, and that is indicates the insulin resistance. And when cirrhosis develops, they present with the symptoms of cirrhosis. They are the symptoms of decompensated chronic liver disease such as jaundice, edema, itchy skin, and other NFLD-associated comorbidities, including insulin resistance and type 2 diabetes mellitus. So NFLD diagnosis depends upon high index of suspicion. When we suspect, when a child presents with clinical features of overweight and obesity, or hypertension, insulin resistance, and if the child is more than 3 years of old, and if the child having family history of NFLD, and if on examination we found that hepatomegaly and acanthosis nigricans, then we go for screening of this patient. And how do we screen? According to NASPGHAN 2017, they recommended that all the obese children should be screened in 9 to 11 years of age, and all the overweight children who have additional risk factors such as central adiposity, insulin resistance, pre-diabetes or diabetes dyslipidemia, sleep apnea, or family history of NFLD or NASH. But sometimes we need also earlier screening. When we do earlier screening, if a younger patient with risk factors of severe obesity, that is, if BMI is more than 35 or more, or obese or obese child with family history of NFLD, or child with hypothyroidism, this child needs early screening. How do we screen this child? According to, I have discussed the NASPGHAN criteria, but according to American Academy of Study of Liver Disease, they don't recommend the screening of overweight and obese children due to paucity of evidence. How do we screen? We commonly use the screening test is alanine aminotransferase and abdominal ultrasonogram. And less commonly used screening tests are MRI, MRS, and CT. They are less commonly used screening tests, but they are very important in diagnosing the hepatic steatosis. So ALT, it is the first line screening test. It is inexpensive and universally available. It's minimally invasive and an acceptable sensitivity. And when it is 2 times upper limit of the normal, that is more than 44 in female and more than 50 milligram in boys, then it gives the sensitivity of diagnosing NFLD in 88% and specificity is 26%. And if ALT is 8 or more than 80 unit per liter, NASH is more common in those children in comparison to those children having ALT less than 80. And abdominal ultrasonography is the most commonly used screening test for non-alcoholic fatty liver disease, which accounts sensitivity about 3. And there are observer variability of the instrument and difficulty in obese patients. Now, for the diagnosis of NFLD requires hepatic steatosis and exclusion. When we found hepatic steatosis, then we need to exclude the other secondary causes. And definitive diagnosis of NASH requires a liver biopsy. That is the only procedure that reliably differentiates NFL from NASH. Now, first we have to look at what are the other causes of steatosis. There are some genetic and metabolic factors. There are some medications, there are dietary causes and infections. There are chronic liver disease, genetic causes among Wilson disease, uncontrolled diabetes, and familial combined hyperlipidemia, and some medications and protein energy malnutrition causes and the infection like hepatitis C also gives hepatic steatosis. So we need to exclude this. So we go for investigation to exclude these diseases. For chronic liver diseases, we need to exclude the causes of chronic liver diseases and need to exclude the causes of raised ALT. As NFLD patient presents with less than 50% patient present with ALT, raised ALT, but not the 100% cases. So if the child present with raised ALT, then we need to exclude the common causes of viral infections and other chronic viral infections. And exclude endocrine disorders, the thyroid stimulating hormone, T4, and exclude autoimmune causes of ALT elevation. And we need to exclude genetic causes of ALT also. But for definitive diagnosis of NASH, we have to do liver biopsy. But do we have to do a biopsy on everyone with fatty liver disease? No, as because it is invasive. So first we will do non-invasive test, and that is imaging. Among the imaging, MRI is the best sensitive tool for diagnosing liver steatosis. Its sensitivity is about 100% and specificity is 90.4%. But the difficulty is it is expensive, and sometimes in case of younger children, their sedation may be required. Next, magnetic resonance spectroscopy. This is an emerging modality of the quantitative assessment of hepatic steatosis, and its sensitivity for quantification of hepatic triglyceride is 87 to 100%, and specificity 80 to 85%. But it's very expensive, and its use is only research purposes. And CT, non-contrast CT scan, is very good in identifying the hepatic steatosis, and its sensitivity is 82% and high specificity. But due to radiation hazard, it's not usually done in case of children. And for diagnosing fibrosis, as we have heard from the first speaker's talk, that there is fibrosis occurs in the advanced NFLD. So to do the fibroscan, it is a non-invasive method of evaluation of stiffness in a non-invasive method. So we evaluate the liver fibrosis. It is rapid, it's painless, and it's reproducible. And sensitivity is 81 to 85%, and its specificity is 74 to 80%. And there are some non-invasive biomarkers. That is, we know the pathogenesis of NFLD the first thing in two-hit theory or multi-hit theory or any theory, the first thing that occurs in the body, that is insulin resistance. So we need to diagnose the insulin resistance by some simple biochemical test. This is fasting blood glucose and insulin, and that is if it is divided by 22.5, that is a constant figure, and if it is more, then it indicates insulin resistance. And there are some biomarkers, but though it is not readily available, but among them cytokeratin 18 fragments is very important, as we have heard that in NAFLD there is apoptosis of cell, and the more the apoptosis, the more the formation of cytokeratin 18, and it's a good marker of diagnosing NAFLD. And in case of children, there are pediatric NAFLD fibrosis index. Earlier it was used, and it's based on the age, waist circumference, and triglyceride is the predictor of liver fibrosis in children. And waist circumference indicates the visceral adiposity, and visceral adiposity is associated with NAFLD. But liver biopsy remains, all the investigations, liver biopsy remains the gold standard. And it's the only mean by which we can distinguish whether it is NFL or whether it is NASH. And when we will do liver biopsy, when our obese children having raised level of transaminases after 3 to 6 months despite gradual weight loss, and enzyme abnormalities persist, and if AST and ALT ratio more than 1, that means that is fibrosis occurs, and if children with hypothalamic dysfunction. In case of histology, in NASH, there are two types of histological features we usually found in case of type 1 and type 2 NASH. Type 1 NASH is more common in adult, and type 2 NASH, that is more common in pediatric age group. And in type 2 NASH, there is the inflammation, that is portal inflammation and portal fibrosis is more than perisinusoidal fibrosis, which is more in type 1 NASH, and ballooning degradation, that is present in type 1 NASH, which is absent in type 2 NASH, and steatosis is present. It's a disease of accumulation of fat, so steatosis presents in both the cases. Now let's come to the management portion, how we treat this kind. This most commonly accepted goal of treatment is to regression of this disease, defined as decrease in steatosis, decrease in inflammation, and or fibrosis. A second accepted goal is resolution of NASH by decreasing ALT is a surrogate marker of improvement in histology of NAFLD. The first line of management is first lifestyle intervention. Lifestyle intervention consists of modification of diet and physical exercise. And as the disease is related to the overweight and obesity, so diet, decreased calorie intake is the mainstay, and decreased fat intake. As there is accumulation of fat, so dietary fat should be restricted, and decreased fructose, as fructose causes lipogenesis, and intake of sugary drinks that will lead to the increased hepatosteatosis. And among the all diet, the Mediterranean diet is the most acceptable diet that can prevent and that can treat the NAFLD successfully. And what does Mediterranean diet contains? It contains whole grain, it contains legume and vegetables, and certain fruits, nuts, and some fishes. And it's very rich in monounsaturated fatty acid and rich in polyunsaturated fatty acid. And it contains rarely meat and very low dairy product. Now we have heard that pathogenesis, that choline deficient diet may cause the NAFLD. So daily consumption of choline can improve the condition. And choline containing diets are salmon, fish, eggs, or vegetables, and some fruits they contain, and beef liver that contains choline. And physical exercise, the target of the physical exercise to reduce the weight, as weight reduction is critically important to treat the disease. And if their studies showed that if 10% weight reduction may result in more than 95% improvement in hepatosteatosis and insulin resistance in adult person. But weight reduction should be sustained, it not rapid. Sustained exercise for 20 minutes or 3 days in a week. In adult, it has been told that 0.5 to 1 kg weight per week is enough to reduce the weight. And reduce screen time in case of children, less than 2 hours per day, and increased family engagement is improve the lifestyle, improve the condition of NAFLD. If this fails, then we will go to the second line of treatment, that is pharmacotherapy. What are the pharmacotherapy? If we think, if we recapitulate the pathophysiology, then we'll see that insulin resistance is the key. So drug that causes insulin sensitizer will improve the condition. And what are these drugs? That are metformin, that are thiazolidinedione, and incretin mimetics. Among them, metformin, it's a drug that reduces insulin resistance and hyperglycemia. And the largest trial on treatment of NAFLD in children, it's a 5-year-long study, and the study RCT was done upon 173 children ages 8 to 17 years. They conducted and they concluded that metformin is not superior to placebo. Another insulin sensitizer, that is pioglitazone, but that is not used in children. That is recommended for adult person. And we have seen that there is oxidant stress in the generation of the NAFLD disease. So, and there is a reactive oxygen species that causes the fibrogenesis and also inflammatory cytokines generation. So drugs that causes the having the antioxidant property will improve the condition. Among them, there are vitamin E and ursodeoxycholic acid. There are very few studies on ursodeoxycholic acid. It's a hepatoprotective, and sometimes it may add an adjunct therapy associated with vitamin A. But tonic trial, the largest trial, that also they give the two drugs, metformin, vitamin E, and along with placebo, and they found that 800 IU of vitamin E significantly reduced NAFLD activity score in 58% of subjects, but ALT reduction was not attained. So American Academy of Study of Liver Disease, they recommend that children with biopsy proven NASH can be treated with vitamin A, but NAFLD of NASH or NAFLD, any type of in NASH1, they doesn't recommend this. As there is the weight loss, some drugs may cause weight loss, that is Orilstat, that is enteric lipase inhibitor, but it is not recommended to treat the NAFLD in case of children. And cholesterol regulation, that is dyslipidemia children, that is statin. Statins, children are recommended children for 12 years of age for dyslipidemic children, but it is not recommended to treat the NAFLD in children. There are some studies about probiotics. As we have heard that in case of pathogenesis of NAFLD, there is a gut microbiota dysgenesis, and that is improved by probiotics. And there are several RCT are done on probiotics recently, and they have found that significant improvement in ALT levels compared to placebo, independent of changes in BMI. So in future, probiotics could be a promising future treatment option for pediatric patients with NAFLD. And when will you do surgery? Oh, there are some novel investigational medications for adult NAFLD, but these are not recommended for children. And third line of therapy is bariatric surgery. What are those surgery? These are gastric bending, these are Roux-en-Y gastric bypass, these are gastrectomy and biliopancreatic diversion. And when we will do this? If the child is severely obese, after all the dietary modifications, physical activities, and drugs fail to improve the condition, then this patient will go to the bariatric surgery. This is the guideline strategy of NAFLD in NASBGAN. In NASBGAN, they advocated the treatment of NAFLD is lifestyle changes, medications for NAFLD, and other interventions. And lifestyle changes is more important, avoidance of sugar, sweetened beverages, and consumption of healthy, well-balanced diet, and moderate to high-intensity exercise daily, less than 2 hours screen time daily. And they didn't recommend any drug to treat NAFLD or NASH. And other intervention, bariatric surgery, which I have told. Now, how will follow up this child? This child needs regular follow-up by clinically and biochemically. How do we follow up clinically? We will see the body weight, BMI for age, waist circumference, because it's very important in predicting the insulin resistance, predicting the NAFLD, and acanthosis nigricans, blood pressure, and hepatomegaly. In laboratory investigation, we will see the LFT, ultrasonogram of liver to see the fat content, fasting lipid profile, fasting blood sugar, fasting serum insulin to see the HOMA-IR, and liver biopsy may be needed in some special cases. So in summary, we can say, what is NFLD? NFLD is accumulation of fat in liver with or without inflammation and with or without fibrosis. Now, how does it occur? It can occur by excessive intake of fat and insulin. This patient, if a patient have insulin resistance, there is oxidative damage occurs and they causes progression of NFLD. How big it's a problem? It's huge problem. In the United States is the second leading cause of liver transplant and it's climbing. How big it is in Bangladesh? Recently, a study done in 2016, that study were done in the Bardem Hospital and hepatic steatosis among obese children and adolescents. They found the prevalence of 36% in obese children. But after 5 years, the study done in BSMMU in 2021, they found that obese children have 40% chance of developing NFLD. So it's climbing also in developing countries also. What populations are at higher risk? Population, those with obesity, those with diabetes, those with hypertension, and Hispanic heritage are risk group. How can we diagnose? We can diagnose by imaging, by diagnosing NASH. Also, there are some special tests which we can do. And how can we manage this child? The lifestyle modification, this is the very important, is weight loss is the key. Thank you everyone for patience sharing.
Thank you, Dr. Fahmida Begum, for your very informative presentation. Now we have few questions. The first question is when we should advise metformin in case of NFLD. I think our second speaker, Dr. Fahmida, has already given this answer. It's an insulin sensitizer. And another question is when to advise the earliest stage and from which age it can be prescribed. So I would like to request our speakers if they want to answer these questions. Indication of earliest stage in case of children.
What is the first? Dr. Rubaya, what is the first question?
When metformin can be, when metformin is advised in case of fatty liver, NFLD, and its relation with HOMA-IR.
Thank you.
Thank you, Dr. Ruba. Thank you for calling your question. But
Sound is not clear. Dr. Fahmida, please unmute yourself. Dr. Fahmida madam, please unmute yourself. Now it's okay.
Thank you, Ruba. Sorry for the technical disturbance. Thank you for the pertinent question. According to NESBUCAN, metformin is not recommended for treatment of NASH. But if the child has concomitant diabetes, then metformin could be prescribed. Thank you. Yes.
Thank you. Thank you, Dr. Fahmida. Now I would like to request our panel of experts if they want to add something.
Can you say a few words? Dr.
Yes,
Ruba,
sir.
can I say
Yes,
a few
sir.
words?
Of course.
Okay. Thank you. I don't like to say any comment because Dr. Lamia and Fahmida has extensively elaborated the topics, so nothing to say. But I should congratulate to Professor Ruknujaman for taking the initiative to organize such a webinar, which I could not. It was my failure during my tenure. So I like to thank Dr. Ruknujaman and the speakers for participating and organizing this type of webinar. I like to thank Professor Syed Safi Ahmad Muazzam to be with us due to his busy schedule. About the topics, I have nothing to say, but I said only a few lines. Number one, fatty liver disease is not only the liver disease in the obese, but it can be seen even in the malnourished children. Even 2% they have been found that it can be seen in malnourished children, maybe due to genetic cause or maybe due to insulin resistance. Another point is that whenever a child presents, whenever a obese child presents with raised ELT, it is 98% that it is due to fatty liver. But there are 2% for which we have to investigate to bad or life-threatening liver cause like infective cause, metabolic cause, autoimmune cause. We should exclude those before finally diagnosis fatty liver disease. Another point is in case of autoimmune hepatitis with low titer of autoantibodies, there may be fat accumulation in the liver. So in this case, biopsy is indicated. Otherwise, biopsy is not usually indicated for diagnosing fatty liver. So which one is the best screening test for fatty liver? Yes, it could be ultrasonography or ALT, but majority recommends biochemical test because in case of obese children due to increased fat in the abdominal wall, ultrasonography may interfere with the correct or final diagnosis of fatty. So majority recommends biochemical test for the diagnosis of fatty liver in obese children. With these few words, I like to thank all, and I like to leave the session because I am very much busy with my some family affairs. Dr. Ruknujaman has already known it. I don't like to discuss it here. With these few words, thank you all and goodbye. Assalamu alaikum.
Thank you, sir. Now I would like to request our panel of experts, Professor Dr. Syed Shafi Ahmed Muaz, sir, if sir wants to enrich us. Say something, sir, please.
Thank you very much. Respected chairperson, honorable panel of experts, dear students and colleagues, assalamu alaikum. First of all, I thanks to speakers for their nice presentation. Since the first report of non-alcoholic fatty liver disease in children in 1980, it has become the most common liver disease among children worldwide. Without weight loss or life and lifestyle modification, therapeutic options for pediatric non-alcoholic fatty liver disease is limited. So it is necessary to recognize the risk factors of non-alcoholic fatty liver disease as it is asymptomatic in early stage. In the late stage, when it is patient is symptomatic, fibrosis and also cirrhosis will develop. With these few words, I want to thanks again to all for patienting. Thank you very much to all.
Thank you, sir.
Okay.
Now I would like to request our panel of experts, Dr. Wahiduzzaman Majumdar, sir, Associate Professor, Department of Pediatric Gastroenterology, to say something about this topic.
Thank you, moderator, for giving the floor. I think I am audible and visible to all. Is it not?
Yes, sir. Yes.
শোনা যায় বলেন
Sir, please continue, sir.
মাস্টার খুলেন
Sir, please unmute yourself, sir. Wahidujaman, sir.
And now it is
Now
clear,
it's okay,
Madam?
sir. Yeah, sir, clear.
Okay. Before that, I have already paid my thanks to the presenters for their brilliant presentation. And now I want to say a few words regarding NFLD. Practically, we are facing the condition actually not so uncommon, as Professor Okunojaman sir said, especially in this COVID situation, pandemic situation. Dr. Fahmida brilliantly presented that screen time should not be more than 2 hours. But what actually going on for the last 14 to 15 months? Majority of our children expenses their whole day in front of screen. So it's a risk factor for nowadays for developing NFLD. And everything I think discussed very nicely. Few words regarding screening. They have mentioned very nicely ALT and imaging, but there is some controversy regarding ALT because some cases of NFLD established NASH was there, biopsy proven, but ALT was normal. So still now it's remain which one is better for screening, and there is no novel biomarker for to identify the NASH, especially NASH, other than invasive liver biopsy procedure. And now regarding fibrosis assessment, we have no good and best tool other than liver biopsy. Yes, there is elastography. They have nicely said that MR elastography is a very good tool, but this is not available everywhere in Bangladesh now, just now, especially in some few centers, these are available. And another difficulty in our situation that man behind the machine, we are lacking expert of that subject. Regarding management, only issue as Nesgan recommended, weight loss, lifestyle modification. In case of pharmacotherapy, we are very helpless. First, there, nothing specially to do. So, especially to halt the fibrosis process, what we should do? There is no novel drug to halt this fibrotic process still now. And there are some drugs, that is obeticholic acid, but and also SGLT2 inhibitors, that is glioflozins. These things are not, I think Professor Okunojaman sir can say especially, these are not allowed in pediatric age. But we are hopeful in future they may be allowed for the pediatric age groups. And especially for histological cure, histological reversal, still now there is no drugs, I think so far. So, and another thing is that this term NFLD is now going to be changed. There is a new term, metabolic dysfunction associated fatty liver disease. Nowadays is going to be used in case of NFLD. So we are in a difficult situation to diagnose this condition, to treat this condition, because pharmacotherapy is not so hopeful. With these few words, I want to pay my special thanks to our Professor Fazlul Karim sir, Professor Shafi Ahmed Muaz sir, both the speakers, moderators, and our students who are joined with us. I want to thank special my thanks to Professor Okunojaman sir to arrange such a program, and we are hopeful in future we will get some program like this. Thank you very much. Thank you for giving me the floor.
Thank you, sir. We are delighted to have Professor Dr. Mamun Al Mahtab, sir, Chairman, Department of Hepatology, BSMMU. He is with us. Sir, I would like to request you to tell us something about this topic.
Thank you very much. I'm firstly highly appreciative of the Department of Pediatric Gastroenterology and Nutrition for very kindly inviting me and connecting me to the greater pediatric gastroenterology community as a panelist here. This is a very burning issue, as we all know, and in BSMMU we are actually neighbors. So the the patients that you manages in childhood actually reduces our burden, because these liver disease patients someday will grow older, will become adult liver disease patients, and will add to our disease burden. So there is the spirit where we should always collaborate. And as the speakers have rightly mentioned, and the panel discussions have also raised the issue that fatty liver in children is now a very growing issue. In adults, we have published from BSMU last year in 2019 that now the second commonest cause of chronic liver disease in patients attending our adult hepatology outdoor is due to fatty liver, next only to hepatitis B virus. And hepatitis C virus is the third commonest cause now for adult chronic liver disease in Bangladesh. Having said so, it is a global scenario that pediatric fatty liver is increasing, especially during this pandemic time. Children are more restricted to the homes, more confined to the different devices for their class, for their entertainment, for their everything. When in the pre-COVID era, it was reported that fatty liver can be diagnosed in children as early as 2 years, and liver cirrhosis can be seen in them as early as 8 years. Now it is probably going to change, and we'll be seeing more and more children with more severe liver disease due to fatty liver. So when we come off treatment, again, there's a bit of frustration. Only vitamin E is there, but again, you cannot use it in case of liver cirrhosis. There are certain cautions that we have to maintain. So the only metformin does not help, pioglitazone does not help, obeticholic acid, saroglitazide, they don't have enough data in children as of now. So the only thing that remains for us is lifestyle modification, and we all know that if one can reduce body weight by about 50%, by about 5%, then about 50% of the liver fat goes, and a reduction by 10% body weight results in reduction of liver fibrosis by 45% or so. But again, this is difficult to accomplish in adults, even more so in case of children. So the basic thing that we have to concentrate as of now, until we have a very good drug or a group of drugs, is that we have to encourage our parents so that the children don't get obese, don't get fatty liver, and if they get fatty liver, they come to you early so that they don't come to us as late progressed liver disease in their adulthood. So thank you very much. I'm once again grateful to Professor Okunuzzaman and my colleagues of my neighboring department in BSME for inviting me in here. It was a very good experience, a good learning experience for me. Thank you very much once again.
For giving your valuable time. Now I would like to request our chairperson of this session, Professor Dr. Mohammad Rukunuzzaman sir, to give his remark.
Thank you, Dr. Rupa. I must thank both the presenters who very nicely presented the topics. I think nothing is uncovered regarding NFLD. And also our panelists, expert panels, also they are very much luminous in their field, especially Mamunallah Mahatab Shopnil, who is junior to me in medical college, but he gathered a lot of experiences, and I think he's an international figure, and about 300 publications. Pediatric population, you know, about 35% patients are pediatric. So the spectrum of the disease in the pediatric population also huge. Our presenter says about 35% patient obese child is suffering from NFLD, and 7% patient who are non-obese but is still suffering from NFLD. So any patient having obesity beyond the age of 9 years should be screened for fatty liver disease, NFLD. Actually, which screening method we can use? It has been a debate also. Oneke bole je ultrasonography is better. Ultrasonography korte gele onek grame ultrasonography kono facilities নাই, সেখানে কিন্তু আল্ট্রাসোনোগ্রাফি করা যাবে না। ওইখানে আল্ট্রাসোনোগ্রাফি করতে গেলে হয়তো যারা আল্ট্রাসোনোগ্রাফি করবে থানা লেভেলে তারা কিন্তু ঠিকমতো পিক আপ করতে পারবে না। আবার দেখা গেছে যদি আমরা ALT এর উপর বেস করি, in a study it was found that about 50% patient of NFLD is missed when screening is done by ALT, because ALT মানে কখন বাড়ে যখন ডিজিজটা এক্সটেন্ড করে কাজে এক্সটেন্ড করার আগে যদি আমরা ডিজিজটাকে ধরতে চাই, আমরা যদি বুঝতে চাই, তাহলে কিন্তু আমাদেরকে মানে এই এএলটির উপর বেস করা যাবে না। আর অন্যান্য যেগুলো আছে বায়োপসি, লিভার বায়োপসি, ইট ইজ এ ডিফিকাল্ট প্রবলেম। এটা তো অনেক মেডিকেল কলেজে লিভার বায়োপসি করে না, শুধু আমরা বিএসএম মধ্যে করি। কাজে লিভার বায়োপসি আমাদের এখানে হইতে পারে, বাট ইট ইজ নট এ গুড স্ক্রিনিং টেস্ট। সো কনসিডারিং অল থিংস, আমরা কোন স্ক্রিনিং টেস্টটা ব্যবহার করবো, আমার মনে হয় যেগুলো যেখানে ফ্যাসিলিটিস যেটা আছে সেটা ইউজ করা যায়। তো আল্ট্রাসোনোগ্রাফি ইজ গুড, কোয়াইট গুড, এন্ড এর সেনসিটিভিটিও ভালো, এবং এটা মানে কিছুটা অপারেটর ডিপেন্ডেন্ট, ঠিক আছে, কিন্তু এটা মানে মোটামুটি অনেক জায়গায় পাওয়া যায়। আর এছাড়া এটাকে বলা এই যে এনএফএলডি, ইট ইজ বলা হয় যে ডিজিজ অফ দিস সেন্সরি, ডিজিজ অফ দিস মিলেনিয়াম। এর আমাদের এই পরবর্তী সেঞ্চুরিতে মনে করেন হেপাটাইটিস এ বি এগুলা হবে না, due to vaccination, due to personal protection, due to safety, due to availability of the medical equipments and others, and improving the lifestyle, gradually those diseases, infectious diseases, will be eliminated, and then only the non-alcoholic fatty liver disease, it will increase. এবং এটা আরো কারণ আছে, রিসেন্টলি ইউসি all the classes is stopped. আমি চেম্বারে অনেক রোগী পাই, মা বলে যে this child was lean and thin, but during this COVID period in 1.5 years, this patient become obese. এবং এদের স্ক্রিনিং করলে কিছু কিছু ক্ষেত্রে দেখা যাচ্ছে এএলটি বেশি পাওয়া যাচ্ছে, নয়তো তাদের সোনোগ্রাফিক্যালি এখানে ফ্যাট পাওয়া যাচ্ছে। সো এই অবস্থা যদি এক্সটেন্ড করতে থাকে, আই থিঙ্ক many children will be affected with NASH, এবং আমাদের শিশুদেরকে should encourage to do the physical activities even in home. In home exercise can be done, or in the open field. যখন open field এ তো হাঁটাহাঁটি করলে কোনো অসুবিধা নেই, গ্যাদারিং না প্রবলেম, but if I walk in the road or in the field, it is not a problem for the COVID dissemination. So I thank everybody, especially the RUBA, who take the pains to moderate this program, and my audience in the COVID condition, in a distressful condition, the huge pandemics, largest pandemics, whatever is I say. এই অবস্থার মধ্যে এতগুলা মানে অডিয়েন্স আসছেন, তারা যোগ দিচ্ছেন, তারা আছেন আমাদের সাথে এবং এনকারেজার্স, এবং আবার মাহতাবকে মানে সব মিলকে আমাকে মানে থ্যাঙ্কস করতে দিতেই হবে যে সে তো তার টাইট শিডিউল, মানে তার টাইট শিডিউলের মাঝখানে আমাদের কাছে আসছে। আমি জাস্ট I called for once, and he said, okay, no problem, I shall give you time. So I am impressed on his behavior, and in future I appeal to the Department of Pediatric Hepatology to collaborate with us. Many activities, many research can be conducted in collaboration with hepatology, and in their program they can also call us. Of course we shall respond to their call. এবং আমাদের হেপাটোলজি ওয়ার্ল্ড হেপাটাইটিস ডে প্রোগ্রাম আছে, সেখানে আমরা যেহেতু ফর হেপাটাইটিস মামুনুল মাহতাব ইজ স্টার, I think I want him in that program also. তো এবং আমাদের শফি আহমেদ মোয়াজ ভাই সো বিজি, ঢাকা শিশু হাসপাতালের ডিরেক্টর হওয়া মানে এটা মানে দেশ চালানোর মতো অবস্থা। এবং স্যারের খবরটা আমি একটু দিয়ে দিই, স্যারের মেয়ের বিয়ে, এই মেয়ের বিয়ে হওয়ার পরে স্যার যে অ্যাটেন্ড করছে, এটা আমি হলে পারতাম না। আমি বললাম ঠিক আছে, আমার ঘুরলে জায়গায় ওয়েবিনার, আমি এই প্রোগ্রামে আসবো না।
ওনার মেয়ের বিয়াতে আমার জামাই পক্ষে ছিলাম, কিন্তু যাইতে পারি নাই। এর আগে
আমরাও তো যেতে পারিনি, কিভাবে যাবেন করোনার মধ্যে। I must thank also our rising star Dr. Wahiduzzaman, who beautifully rising in this field, and he also beautifully presented and give his opinion. And with this word, I want to conclude this session. Thank you, everybody.
Just 1 minute, sir. Sir, before concluding the session, Mr. Kutbuzzaman from our scientific partner of Sunin Pharma will say few words to us.
Okay, thank you. Kutbuzzaman bhai bolen. Ji.
Mr. Kutbuzzaman.
Assalamu alaikum, Honorable Chairperson, Professor Dr. M. D. Rukunujaman, Chairman, Department of Pediatric Gastroenterology and Nutrition, BSMMU, Honorable panel of experts, and today's respected speakers, and today's moderator, and respect all doctors, those who are in online and joining in this webinar. Thank you very much for give us this scientific partnership. As Opsonate Pharma Limited, you know, we are a legendary and modern pharmaceutical company in Bangladesh. We are always eager to conduct this type of webinar and scientific session, and especially thanks today's all doctors, panelists, and chairpersons are for attending this session effectively, and they are continuing their valuable time. So once again, thank you very much for as a scientific partner, Opsonate Pharma Limited. Assalamu alaikum.
Thank you.
Dr. Jaman. Sir, I think we can conclude the session.
খালি মুখে বিদায় দিলেন ম্যাডাম।
It was such an amazing session, I think, and hope to meet you all soon, inshallah.